Good evening, good morning, good afternoon, dear colleagues, dear friends. It is a real pleasure to welcome you all to this ICH webinar dedicated to the latest therapeutic advances in multiple myeloma as presented at the 2025 EHA and ASCO Congresses. Actually, since the launch of the ICH activities in 2018, this post-Congress webinar has become a cherished tradition, an opportunity to come together and reflect on the most impactful developments in our field. For today's session, I have selected a number of studies that I believe are particularly important and potentially practice-changing. Of course, due to time constraints, we cannot cover every noteworthy contribution, and I would like to acknowledge the many other important abstract and presentations that also deserve recognition. Thank you for joining us. I look forward to an engaging discussion. These are my disclosures. So we'll make it quite simple, actually, and we'll start with the traditional different chapters. First, the therapy of transplant-eligible patient. And I'm sure most of you realized or acknowledge that this MEDAS trial that was also published in the New England Journal of Medicine a few weeks ago by Dr. Perot and colleagues is truly a major highlight of these congresses, and it is the first prospective randomized trial which has established the value of an MRD-driven strategy. You can see the study design here. Everybody among these patients received the induction with isatuximab, carfilzomib, lenalidomide, dexamethasone, 6 cycles, 28 days cycles. Stem cell collection occurred after 3 cycles. MRD was evaluated, and with a threshold of 10-5, actually patients were divided into MRD negative, standard risk, versus MRD positive, high risk. And among the standard risk, the randomization was with or without transplant. In the high risk, the randomization was between tandem auto and single auto plus consolidation, and of course, use of a new cell mode, iberdomide, for maintenance for 3 years. You can see the results of MRD status at the 10-6 level in arms A and B, which means these arms, the standard risk, those patients who were already in MRD negativity after 6 cycles of induction. And to make a long story short, actually post-consolidation, we don't see any significant response in terms of MRD. In another word, a single transplant doesn't bring much in terms of deepening the MRD. And when you look to the subgroup analysis, actually, this is likely true in all subgroup disease features or patient characteristics when you compare arm E to arm B. When it comes to arm C and D, this is the high-risk MRD positive patient, and I would like to emphasize that disease biology, the cytogenetics in terms of risk assessment was not taken into account, and this is an important issue to consider when analyzing these results. And here, the conclusion from arm C and D that it is likely that tandem auto, double auto is not necessarily useful in terms of outcome. And the key takeaway points from the study was that in MRD negative patient following ESA-KRD, this is not something else, ESA-KRD, an anti-CD38, a second-generation proteasome inhibitor, auto-transplant consolidation did not improve MRD negativity rate compared to continued isatuximab-KRD. In the MRD positive patient, tandem auto did not provide additional benefit in terms of MRD negativity compared to single auto. Of course, we don't have yet the PFS data, but these conclusions are clearly very important. And MRD is becoming more and more, I think, a key endpoint. And you may remember last year, the ODAC positive voting in favor of considering MRD as a primary endpoint in clinical trials. And during ASCO and EHA, we had the update of the ISKIA trial, the phase 3 ISKIA trial from the European Myeloma Network by Dr. Francesca Guy, sustained MRD negativity in patients with newly diagnosed multiple myeloma treated with carfilzomib, lenalidomide, dexamethasone, with or without isatuximab. So you can see here the design of the trial. Here we're randomizing for induction a triplet versus a quadruplet with an anti-CD38 monoclonal antibody, namely isatuximab, mobilization, stem cell mobilization, auto-transplant, consolidation, post-auto, 4 cycles, but also a relatively light consolidation, but still 12 cycles of KRD or ESA-KRD. And you can see on the intention to treat analysis, the 1-year sustained MRD negativity rate, clearly a significant benefit in favor of the quadruplet, further highlighting the importance of using anti-CD38 monoclonal antibodies frontline. And this is favorable in all subgroup considered. And the key takeaways from this ISKIA trial is that this specific regimen, ESA-KRD, which is not approved, of course, yet, significantly increased the rate at the threshold of 10-6 of 1-year sustained MRD negativity compared to the triplet KRD, including in the high-risk and very high-risk patient. And the rate of early relapse was low in both arms. Another important piece of information is the safety profile of ESA-KRD, and this treatment was tolerable with no increase of toxicity compared to prolonged therapy. And last but not least, it is obvious that this 10-6 MRD negativity cutoff is the most informative. You've seen the data from MIDAS. We have now ISKIA. And that brings me actually to something that was also discussed during the EHA meeting, and it was published a couple of weeks ago. This is the International Myeloma Society International Myeloma Working Group consensus recommendations on the definition of high-risk multiple myeloma. And this is something we've been waiting for more than 2 years. And you may have seen the papers. This is the summary of these new definition. And the definition of high-risk multiple myeloma is about deletion 17p and or TP53 mutation. One of these translocation 414, 1416, 1420 co-occurring with 1q plus and or deletion 1p32. We have also monoallelic deletion 1p32 along with 1q plus or biallelic del 1p32. High beta-2 microglobulin with normal creatinine remains an important characteristic. And this paper was discussed, and the key messages here is that probably these new high-risk subsets should represent around 20% of newly diagnosed multiple myeloma. We believe that this represents an important step toward risk-stratified therapeutic approaches in routine It is an NGS-based definition, but the FISH data are also acceptable. Obviously, there's a question mark about whether we need an ultra-high-risk definition. And the co-authors and the community hopes that this definition will promote the design and conduct of clinical trial focused on patients with high-risk multiple myeloma. And this is exactly what has been done in the GMMG concept trial that was updated. It was already published in JCO, but it was updated during these congresses. And this trial, again, a reminder, included both transplant eligible and non-transplant eligible. Arm A was about transplant eligible patient. We have now 219 patients who received, again, this very potent induction regimen with ESA-KRD, stem cell mobilization, high-dose melphalan auto-transplant, 4 cycles of consolidation with ESA-KRD, and 26 cycles of maintenance with carfilzomib lenalidomide. I will not go into all the details of the characteristics of the patient, but you can notice that by definition, these are intermediate high risk R2 ISS patient, and you can see the different high risk cytogenetic abnormalities that were included. So it truly a phase 2 trial dedicated to the high risk patient, although it didn't use the new IMS-RMW criteria. And the primary endpoint was met with an MRD negativity rate after consolidation of 73.2%. This is quite incredible. And almost 87% reached MRD negativity at any time. And of course, most importantly, you have a very high rate of 1 year sustained MRD negativity and 2 year. At 2 years, it's almost 41%. And my feeling that if you have 41% with sustained MRD negativity at 2 years, these are patients who are likely going to be cured. And you know, you are well aware that now the big debate is about defining cure, and IMS and IMW are working on this, and hopefully by next year we will hear more. You can see this MRD negativity, high rate of MRD negativity will translate into very beautiful curve of PFS, but also of OS. Median PFS, 73 months in a high-risk population. And of course, if you compare MRD negative status versus non-MRD negative status, I think it doesn't need a long speech to describe the value of MRD negativity. So the key takeaway points here were about ESA-KRD in induction and consolidation with triplet ESA-KR maintenance will induce a high rate of MRD negativity, sustained MRD negativity, and of course, improved outcomes supporting the use of such regimen. But the role of MRD negativity and the value of sustained MRD negativity was also evaluated in the seminal Perseus trial. Remember, this is a trial that was published in the New England Journal of Medicine in January 2024. This has led to the approval of daratumumab, bortezomib, lenalidomide, dexamethasone for induction, and in Europe, it allowed the approval of daratumumab, lenalidomide maintenance, which is something completely new compared to the historical use of lenalidomide alone. You can see the study design, but I'm sure you've seen this design dozens of times. So here, and these are the original results at the initial publication, showing an incredible 48 months PFS of 84% at versus 67% when comparing DARA VRD versus VRD. And again, this is in line with deep and durable MRD negativity thanks to the use of quadruplet. But the key message from this analysis, this update that was presented at ASCO and EHA, is shown here. And this is the PFS by sustained MRD negativity, 10-5 in those patients in CR. So you can see sustained MRD negativity after 1 year in patient in CR, 10-5. This is 65% versus 30% in VRD. And when you look to the shape of the PFS, it is unbelievable. At 4 years, you have 95%, 0.3 for DARA VRD, 94.2 for VRD, sustained MRD negativity. And of course, it's even better when you consider the PFS by sustained MRD negativity 10-5 in CR over 2 years, almost 99% PFS at 4 years, which is, of course, something we've never seen before in the field of myeloma. And this is likely can explain actually the other work that was presented, which I'm not showing here, that maybe one can speculate that the median PFS in this trial actually is around 200 months, which is quite incredible. And you can see the conclusions here from this presentation. The rates of relapse or progression within 18 months of treatment initiation, these so-called functionally high-risk disease, were lower than seen in all other frontline trials. And of course, I think there is no discussion, no debate about whether we should or we should not use DARA VRD plus DR maintenance, because this is about deeper and more durable responses, but also improved PFS. But you can appreciate here, we have an approved regimen. This is a standard of care DARA VRD plus DR maintenance. According to EMA, FDA didn't approve DARA-LEN maintenance. But of course, the devil is always in the detail, because in the ISKIA, in the GMMG concept trial, in the MIDAS trial, I think the use of carfilzomib, which is a second-generation proteasome inhibitor compared to bortezomib, probably is allowing to upgrade the level of MRD negativity. So if you summarize emerging data from the MRD-driven trials, I tried to put here one slide. The master trial, I'm not mentioning it because it's already published, presented several times, allowed us to conclude that we should not discontinue treatment early in the high-risk population, high-risk cytogenetics, despite MRD negativity. The MIDAS trial is telling you that tandem transplant can be probably abandoned. A single transplant can be maybe deferred in the MRD negative patient. And I'm saying maybe because these are not final conclusions. So let's be very precise in our conclusions. The Perseus trials actually is showing the value of sustained MRD negativity. Very quite incredible, 98, 99% PFS if you have a sustained MRD negativity after 2 years. And then, of course, the question that will emerge at some point is about whether we will see relapses during maintenance if we have an early discontinuation of daratumumab. Of course, we don't have yet randomized trials in the high-risk population. In other words, should we consider different strategies for high-risk cytogenetics? And of course, could MRD after induction serve as an early stratification factor in everybody? Because in the MIDAS trial, we've seen slow responders, such patient with translocation 11-14. So a lot of topics that need to be debated. So let me move now to the therapy of non-transplant eligible patient or transplant ineligible patient. Well, I think all of you are well aware that the standard of care until very recently in this non-transplant eligible population was the DARA-LEN-DEX combination. Last year, we've seen the advent, but also approval of quadruplets, such as isatuximab VRd or daratumumab VRd. The emerging data now are about incorporation of bispecific antibodies frontline in combination with daral index. And this is the magnetism MM6 trial that was presented during ASCO and EHA using elranatamab, which is a BCMA bispecific antibody. Well, of course, we are in a phase 1/2 study, so relatively preliminary and feasibility data looking into the optimal dosage, so different dose levels. But the most important part, these are truly non-transplant eligible patients. 37 patient, median age 75, up to 83. And you can see that 24% of these patients were considered as frail, which is, of course, is important when analyzing the results. The first good news is about treatment emergent adverse event. And I would say there's nothing new or worse than the classical side effects we see with daral index or with ELRA alone. Of course, we see CRS, but all CRS were less than grade 2. Of course, the key issue when you add an anti-BCMA bispecific antibody is about the rate of infections. And we have up to 70% of patients getting an infection. But again, less than 20%, 19% had grade 3 and 4. And I think we are clearly improving when managing these patients with prophylaxis, with anti-infectious agent, but also with immunoglobulin replacement therapy. Up to 92% received immunoglobulin replacement therapy. In terms of efficacy, you can see here the overall response rate, and it is really beautiful, 97%. And interestingly, when they respond, it's always more than VGPR, and it occurs very quickly in 1.5 months as a median. So I think we have to watch out carefully to these new trials combining bispecific antibodies plus a standard of care, because these bispecific antibodies are likely moving into the frontline therapy. The other key study that was presented during ASCO and EHA is the Heraclea study. And this was actually published recently in JCO by Dr. Sikander Al-Awadi from Mayo Clinic. It's an international phase 3 non-inferiority randomized trial, actually testing the new formulation of isatuximab, the subcutaneous isatuximab, using an on-body delivery system or on-body injector, if you prefer, versus the well-established approved IV form in combination with Pomdex. Remember, Isa-Pomdex is approved based on the Icaria trial. Just 1 minute to show you what is this on-body delivery injector. It's a sterile, single-use, user-filled wearable injector nested in a filling base. No batteries, no electronics, no AI, nothing sophisticated. You can see it's a relatively small device. It has the filling gauge here. It has an adhesive tab, a button and a window which let the user to track the progress during administration. You use a flat dose, no adjustment for body weight. It's a hands-free administration. There is a hidden small needle. Actually, the user does not see the needle before, during, or after administration. So no risk of injury. And this is how it looks like. The patient can do it alone. And actually, in this trial, using this subcute formulation of isatuximab plus the on-body injector, it was compared to the ISA IV plus POM-DEX. It is a non-inferiority trial. I will not go through the baseline characteristics, phase 3 randomized, usually typical patient for a relapse setting using ISA POM-DEX. And you can see that the co-primary efficacy endpoint when it comes to overall response rate was absolutely superimposable between the two arms. When you look into the PK co-primary endpoint, again, there are no differences. And if you look to another key secondary endpoint, which is patient satisfaction, because obviously it is about bringing added value to the patient. Because one may wonder, why do we need another subcute formulation of an anti-CD38 monoclonal antibody? Daratumumab was there and doing the job. But here, thanks to this on-body injector or delivery system, actually we are able to achieve up to 71% of high of patient satisfaction with the IV form versus 97%. Almost all patients were quite happy about it. And the other important piece of information is about the infusion-related reactions, which are almost negligible, almost inexistent, 1.5% when you use this subcute on-body injector. So truly a major study allowing actually this on-body injector allows to deliver the drug in a median of 13 minutes. And in the majority, it's in less than 20 minutes. And of course, the key takeaways by the authors, these results demonstrate that ESA subcute using on-body injector offered the same level of efficacy and pharmacokinetics as ESA IV, meeting non-inferiority. And patients receiving and using this on-body injector hands-free expressed higher satisfaction with their injection method than the IV form. And we have a similar safety profile with no unexpected safety signals. So a true advance. And I like this kind of progress, because we always think that progress is about bringing in new drugs, which is true. But also we need to take into account the tools to deliver these new drugs to make the life of the patient easier, more comfortable, give them more autonomy. And this is definitely the OBI role, the next generation way of injecting these drugs. And of course, the healthcare professionals, our nurses, are extremely happy, avoiding, to spend minutes doing the subcute. And if you have 10, 15, or 20 patients per day to do it, I can tell you it's not an easy job. Let's move now to the immunotherapy and, of course, to the relapse setting and to CAR T cells. Well, first of all, let me highlight the incredible, value that these immune therapies, whether CAR T cells or bispecific antibodies, are bringing into the field. If you compare to our historical classical drugs, where the response rate in the relapse setting has been always around 20-30%, here in a very highly advanced population, we are able to achieve a very high response level of responses. And the wonderful news during EHA and ASCO came from the long-term, actually more than 5 years, update, remission, and survival when using cilta-cel in the CARTITUDE-1 trial. Please remember, the CARTITUDE-1 trial, this is a trial that was already published and led to the approval of cilta-cel in the relapse refractory setting. 97 patient phase 1/2 trial. And the fantastic news about this long-term update, at 5 years, we have a median follow-up of 61 months. At 5 years, you can see roughly 30 3% of the patient were treatment and progression free. And this is something we haven't seen before in any relapse treatment setting. And I kindly remind you that these are patients who received a median of 6 lines of prior therapies, highly advanced population. So this is showing truly the power of immune therapy and the capacity of CAR T cells, especially cilta-cel, to induce such great long-term outcome. You can see the survival median OS, 5 years, 61 months. I'm not aware of any trial showing such a high rate of overall survival in a population which was so heavily pre-treated. What about safety over the long term? No new cases of Parkinsonism or CNP, cranial nerve pulse. No additional cases of secondary primary malignancies. 2 additional cases, but both were solid tumors. No, when it comes neurologic event, encephalopathy, disorder. So really, no truly long-term concern about the side effects that we were worried about, the Parkinsonism, about the cranial nerve palsy. Actually, it doesn't seem to be worrying, but this is the first evidence of the curative potential of cilta-cel in such population. And of course, because now cilta-cel is also approved in early relapse, you can use it as second or third line, one may wonder what will be the outcome of these patients, and I'm quite positive about it. But the story of anti-BCMA CAR T cells in myeloma will not stop with the approved construct, namely ide-cel and cilta-cel, because we have new players coming into the field, namely anito-cel. And anito-cel is a very unique, actually, construct. It has this D domain, and the D domain attributes are very important in terms of efficacy and safety. They are summarized on this slide. I will not go through the details, but what I would like to share with you is that in this so-called Imagine trial that was presented at EHA by Dr. Kaur and colleague, traditional lymphodepletion. These are patients in relapse. You can see 117 patients, median age 64 up to age 78. So eligibility to CAR T cells is different compared to eligibility for auto-transplant, for instance. 15% had extramedullary disease, 86% triple class refractory, 40% penta refractory, and 79% received prior auto-transplant, 75% received the bridging therapy, and in 9%, 10 patients received it outpatient. Efficacy, 97% overall response, and the majority of these responses are above BGPR. The follow-up is still relatively short, 12 months, but still, I think we have 93% of evaluable patients were MRD negative at the 10-5 sensitivity. And the time to the first response was only 1 month, the median time. And the median time to MRD negativity was also 1 month. So really, very impressive, rapid response. And I think we need to, we are a lot excited about the advent of anito-cel. You can see here the PFS rate at 6 and 12 months. And of course, now the next step is about performing a randomized trial in the relapse setting. And this is now ongoing. Actually, the Imagine 3 design global phase 3 study now enrolling, comparing anito-cel to standard of care relapse treatment with carfilzomib, daratumumab dex, pomalidomide, bortezomib dex, daratumumab pom dex, carfilzomib dex, etc., etc. While talking about immunotherapy, immune modulation, we should not neglect the next generation IMiDs or cell modes. And I know there is some frustration that the development of cell modes has been relatively slow, while we all remember lenalidomide and pomalidomide are really true backbones of the treatment of multiple myeloma. So I selected one study here looking into mezigdomide plus dexamethasone and a proteasome inhibitor, bortezomib or carfilzomib, in patients with relapsed refractory multiple myeloma. I will not go into the details of the mechanism of action of these new IMiDs, the cell modes. They are oral drugs. They bind the cereblon and modulate its activity to induce proteasomal degradation of Ikaros and Aiolos, leading to higher multiple myeloma cell killing and immune stimulation versus the IMiD. So really the added value is more killing and more immune stimulation. And this has been shown in vitro and in vivo. This is an ongoing dose escalation, open label, phase 1/2 dose finding, dose expansion clinical trial. And you can see we have mezigdomide, bortezomib dex, mezigdomide, daratumumab dex, cohort C, mezigdomide, carfilzomib dex, mezigdomide, elotuzumab dex, etc., etc. Again, the characteristics of the patient are typical of relapse high-risk population. And actually, when you look into the cohort D, because this is here what is, I think, is more exciting and very convincing, mezigdomide plus carfilzomib dex, you can appreciate actually the deep and durable responses over time. So, when you look to cohort C with mezi KD, actually, there is efficacy at all those levels. So really, very important news, and we should not neglect the advent of these new cell mode, whether mezigdomide or iberdomide. I mentioned iberdomide, which is used in the MIDAS trial for maintenance. But I think these new cell modes will become great partners for all our available drugs, but also for our immune therapies, CAR T cells, or bispecific antibodies. And that brings me to the bispecific, trispecific chapter. So we all know that bispecific, the anti-BCMA, bispecific anti-CD3, we have 3 drugs approved, 3 antibodies. The first one was teclistamab, then we had elranatamab, and recently we had linvoseltamab. So absolutely great news for the field. But these approvals are single agent. And what you will see more and more, I will not go because we don't have the results yet, but now we have studies combining these bispecific antibodies with the other standard of care combination in relapse. This is just one example, but this is about elranatamab compared to elotuzumab pomdex, pomalidomide veldex, or KD. So trying to bring these bispecific antibodies into earlier lines of therapies, but also, I think, combining them with our current use agent. And I chose here, but we have data from teclistamab, from elranatamab, the linvoseltamab combined with carfilzomib from the Linker MM2 trial presented by Dr. Manier and colleagues. Again, it's a phase 1b trial, single arm. There is a step-up dosing, and you can see the specificity of linvo. It's an IV drug, but the cycles are longer. And you can see here the characteristic of the patient. Again, median age 70, so a truly older population. Soluble BCMA was measured, which is an important piece of information. And these patients, some of them, majority were exposed to bortezomib, very few to carfilzomib, and of course, some of them were refractory to bortezomib. And it's very interesting to observe that when you combine Linvo plus carfilzomib, it looks like to be a nice partner. You have almost 100% response rate, which is, of course, a good start to improve the duration of response, but also to achieve a great PFS. And the key takeaways, because these are still preliminary data, small number of patients, short follow-up, but still, I think that the combination therapy of an anti-BCMA, anti-CD3 bispecific antibody like linvoseltamab plus carfilzomib will achieve a very high response rate. We've seen this with elranatamab and teclistamab. And of course, all of these ongoing data and studies support the continued development of Linvo and other bispecific antibodies in combination with the classical agent. But it's not only about the classical agents plus bispecific. One may wonder why we can't combine two bispecific antibodies, of course, targeting two different tumor antigens. I mentioned teclistamab was the first anti-BCMA bispecific antibody to be approved, and we have talquetamab approved, and it targets GPRC5D. And here, Dr. Kumar presented the phase 2 study combining talquetamab and teclistamab in patients with extramedullary disease. So really the hardest to treat patient. Single arm, the classical step-up dosing, talquetamab and teclistamab, both of them are subcut. The primary endpoint is about the overall response rate. 90 patients, true extramedullary plasmacytomas, up to 40% had non-secretory or oligosecretory, which I think it's an important information. And also, almost 30% received an anti-BCMA CAR therapy and a bispecific therapy. So you can see the distribution here. 18 patients had an anti-BCMA CAR T, and 8 patients, 9%, had a bispecific therapy. So very unmet need. And despite this is the first time we see such high response rate, 79% in true extramedullary disease. So it's offering a lot of hope in this desperate situation. And of course, it's not randomized, but you may wish to compare it to the results from single agent talquetamab or teclistamab in a similar population. And you can appreciate that we are far beyond the 43% threshold. And it gives you a median PFS of 15 months. And this is very high if you compare it to the historical literature data we have in this population. So very attractive, of course, not approved yet. We're not allowed in theory to combine these two bispecific, but this is really very promising, especially that when it comes to side effects, we have to acknowledge there is a relatively high rate of grade 3, 4, 5 infections, but they are mostly limited to early cycles. And we hope that this will be minimized thanks to the vigilant anti-infectious prophylaxis and management, but also to the supplementation with immunoglobulin. So a true turning point, I think, maybe we'll have some solutions to be offered soon for extramedullary disease. Well, the next question you may wish to ask is, if you're able to combine two bispecific antibodies targeting two different antigens, tumor antigens, why not using a trispecific antibody, so a single drug, but targeting CD3 and two tumor antigens. And this is exactly what has been shown in this first-in-human study testing the JNG 5322 next-generation trispecific antibody. Phase 1 data, and you can see here the structure of this trispecific actually targeting CD3, but also linking GPRC5D and BCMA. So it's a dual antigen trispecific antibody, dual tumor antigen. So you may achieve all the benefit of combining two bispecifics by using a single drug. These are the characteristics of the patient. Again, this is a dose-finding study, phase 1. Median prior line of therapies was 4. But most importantly, you should notice that many of these patients were exposed to BCMA therapy, BCMA targeted therapy, or GPRC5D targeting therapy. So what about tolerance and infections? Well, you can see, like with bispecific, we're still, I think, seeing and struggling with infections, but it doesn't seem that you are having higher incidence of infections, because you can appreciate that the grade 3 and 4 was less than 30%, 28.6%. The other side effects are in line with what we know. And maybe interestingly, when it comes to targeting GPRC5D, the nail and skin related, but also taste related side effects are likely much lower than what we've seen with talquetamab alone. So here you can see the details of the infections. And again, I think we have to be aware and apply the most stringent rules in terms of infectious, anti-infectious prophylaxis, but also immunoglobulins. You can see here the 100% response rate at the 100 milligram every month, every 4 weeks. It's quite impressive, especially in the BCMA GPRC5D naive. Even in those who were exposed, you can anticipate a 55% response rate. So clearly, while bispecific antibodies are not available everywhere, it's quite incredible to see that trispecific are now being so quickly developed. And to be totally balanced, there is also another bispecific, trispecific antibody being developed, namely the ISB 2001. We've seen at the last ASH 2024 annual meeting the presentation of the data from this ISB 2001 trispecific targeting CD38 and BCMA, so different from the JNG 5322. So the conclusion here, probably these trispecific, and this one particularly, is the future. Subcute monthly administration, reduced step-up dosing, improved or similar safety profile compared to the equivalent bispecific antibodies. Grade 3 and 4 infections are still occurring in 1/3 of the patient, but the response rates are above the 90-95%. So in summary, my key takeaways from the ASCO and EHA 2025 annual meeting, and of course, I couldn't include all the superb studies that were shown. MRD is a key treatment endpoint now and decision tool. The MRD-guided strategies are gaining momentum, supporting more personalized approaches in both transplant-eligible and ineligible patients. We have new data confirming the value of quadruplet combinations incorporating isatuximab or daratumumab, particularly improving depth and durability of response. I would like to highlight and emphasize the innovative role of delivery, the role of innovative delivery methods especially the on-body injectors, which will improve the patient quality of life and satisfactions. When it comes to immune therapies, whether CAR T cells, bispecific or trispecific, they're completely reshaping the therapeutic landscape. And these developments will point towards deeper, longer-lasting remission, increased feasibility of individualized chemotherapy-free strategies. And it is likely that we will cure more and more patients. And this is really amazing news for the patient, for us in the field, for the healthcare professionals, and to the community as a whole. So I'd like to thank you all for your attention, and we'll take a few questions, and we have a lot of questions. Oh my God, I do apologize, and we may not be able to handle all of these questions you have, because otherwise we'll spend the whole evening and night today. One question here, do you give patients with multiple myeloma any algorithm to cure? Well, I don't know what do you mean by algorithm to cure, but definitely I do give them a lot of hope, and I do insist on the possibility of cure. Myeloma, a diagnosis of myeloma is absolutely not a death sentence today, because we have incredible advances. And I told you in the speculation of the in the calculation or anticipation of the Perseus long-term data, one can anticipate up to a median of 200 months of PFS in the elderly population, Cepheus or IMROS trial, non-transplant eligible. You can expect a median PFS of 100 months in a population above age 75. So clearly, yes, cure is on the agenda. We have a question about MRD negativity using mass spectrometry. Yes, I didn't mention this, but you're right. It's a great question. And today, MRD is mainly tested in the bone marrow, and you need to do a bone marrow aspirate. However, maybe at some point in the next couple of years, we'll have highly sensitive tools using mass spec. And for instance, we had presentations from Mayo Clinic, studies done by Sebia with a new technology, clearly showing that a non-invasive blood test with mass spec can complement or maybe at some point replace MRD. We have a question here about maintenance after transplant and the role of len, bortezomib, and then, of course, now Dara plus len. Well, historically, the approved drug is lenalidomide single-agent maintenance. Of course, in some older trial, in the high-risk population, we have used bortezomib. However, use of bortezomib is not really convenient every 15 days. This is how it has been done. The recommendation today, at least the approval by EMA, in my opinion, and I personally, this is what we decided to apply in our patient, is to use daratumumab lenalidomide maintenance to all patients. We have a question, well, I'll reply very shortly, whether there is still a role for allogeneic stem cell transplantation. Well, there's no answer for this. If in view of all of these available therapies, actually, I believe there is little room for allotransplant. Of course, if you don't have other treatments, if you have no CAR T cells, no bispecific, no treatments, you may wish to consider, especially in a clinical trial, the use of allotransplant. But this has to be discussed on a case per case. For the sake of time, I will not expand on this more. Extramedullary disease. How do you treat these patients today? Well, I showed you that the best results are the ones which are achieved with actually combining two bispecific antibodies. Of course, I'm well aware that this may not be feasible everybody. So today, actually, what we try to do is to give them conventional chemotherapy to try to reduce the tumor load before giving them bispecific antibodies or CAR T cell. We have a question here. Do you prefer CAR T cell or bispecific antibodies? Well, actually, we need all of them. If we have a choice, and if a patient is eligible to both bispecific and CAR T cell, of course, most experts will recommend to use CAR T cells, because CAR T cells allow the patient to enjoy some treatment-free interval. And I have shown you the incredible results over the long term of cilta-cel, actually. We have a question here about the ISKIA trial and the long-term use of KRD and its toxicity and safety. The short answer, at least based on the clinical trial, the ISKIA trial, is that actually it is feasible, it is safe, there is no safety signal about it. We have a great question about the role of melflufen, and I didn't mention it because there were no new news, I would say, about melflufen. But melflufen is definitely an important peptide conjugate, which is approved in Europe in the relapse refractory setting, and it is providing a lot of benefit to many patients, especially, for instance, extramedullary disease, but also as a bridge to some immunotherapies, but also if for whatever reason the patient are not eligible to the different bispecific antibodies. I'm trying to read these dozens of questions. So we have our friend from Poland, Dr. Artur Jurcin, asking whether we use bispecific antibodies, teclistamab or ranatamab or talquetamab in the outpatient clinic. Well, this is now a work in progress, and I'm aware of many programs, and actually the ICH did a webinar, a journal club, about developing an outpatient program for bispecific. So this is something under development. There are now more and more criteria and rules to establish these outpatient programs of bispecific. So Artur, clearly this is something you can consider. We have an interesting question I didn't allude to by Dr. Farid about what about combining CAR T cells and bispecific? Well, actually, this is a very interesting question, Dr. Farid. Actually, I don't have data to show you, but there is a trial, for instance, by Dr. Nupur Raje, combining actually a CAR T cell and consolidation maintenance bispecific with a bispecific. So work in progress. We'll see how it goes. We do have another question here. Wow, it's a long one. To try. Oh, okay. Excellent question. So ISA VRD and DARA VRD are the quadruplet to be used in elderly but fit patient. And you're right. Actually, these regimens are approved. And the question is, can we use a light version of these regimens in old but more fragile patient or frail or intermediate fit? And my personal answer is yes. We can imagine or envision quadruplets to everybody. But of course, you need to be careful. It shouldn't be the same regimen. And we have, for instance, the isatuximab VRD combination, which was, you have a light version of this published in Lancet Hematology from Dr. Frederick Schofield about the REST trial using ISA VRD, but with discontinuation of dexamethasone, but also adjustment of the dosage of bortezomib. And actually, in terms of responses, but also in terms of safety, it works. So to make a long story short, to answer your question, yes, we can use quadruplet in the older and intermediate fit patient, but obviously this has to be done very carefully. I'll take one last question. In a high-risk MRD negative patient to 10-6 for 12 months, do you use continuous Dara-Len for maintenance? My short answer, Dr. Companion, yes. This is a question from Dr. Alfonso Companion. For the sake of time, we are already 1 minute past the hour. I would like to conclude this webinar. I want to warmly thank you for joining us in this rich and forward-looking discussion on the latest therapeutic advances in myeloma as presented at EHA and ASCO. Since the launch of the ISH 2018, this post-Congress I mentioned to you has become a cherished tradition, an annual opportunity to gather a global community to reflect on the progress and look ahead with hope and determination. And I've seen that many patients are watching us and patient advocacy group. So there is a lot of hope. The momentum in this field is extraordinary. And together, we remain committed to turning innovation into better outcomes for patients. Thank you once again. And I look forward to seeing you at our next ICH event. Please stay safe, keep well, and stay inspired. Thank you.